Welcome, everyone. We'll just wait a couple of minutes for people to join.
Supriya, you're muted if you're speaking to us.
Thank you, Maria. Good morning, good afternoon, good evening. Welcome once again to another EPI-WIN webinar. Welcome particularly to those of you who are far away, where it's early in the morning or late at night. We thank you for being here today. For those of you who are new to EPI-WIN, it stands for the WHO Health Emergencies Information Network for Epidemics, and we aim to make information on health emergencies accessible, understandable, and actionable. Today we have a very exciting list of panelists, experts on influenza. Uh, Many of you may have actually had influenza last summer. We're going to be talking about last winter, seasonal influenza update on the situation in the Northern Hemisphere. We have Dr. Maria van Kerkhoff, who needs no introduction. She's the acting director of Epidemic and Pandemic Management Department at WHO, giving the welcome remarks, followed by Dr. Aspen Hammond, who will be giving an overview of the global situation today. Then we hear from Professor Maria Zambon about the situation in the UK, and that's for the Northern Hemisphere. And from the Southern Hemisphere, we get the perspective from Professor Ian Barr. Moderating today's session will be Dr. Wenqing Zhang, who again needs no introduction in the influenza world. She's the unit head for the Global Respiratory Division here at WHO, and has been leading the global influenza program for many, many years now. Without any further ado, I'd like to invite all of you to introduce yourself in the chat, but put your questions in the Q&A box. This webinar is being recorded, and the recording will be uploaded to our website and shared for the public. So if you feel you've missed it, you can go back and listen to the recording again. Now we'd like to welcome Dr. Maria van Kerkhoff to provide the opening remarks. Over to you, Maria.
Thank you, Supriya. Hello, everybody. Good morning, good evening, wherever you are. Thank you so much for joining this webinar today. So just very briefly from me, I think all of you know influenza very well, but seasonal influenza epidemics occur every year, and it's estimated that there are approximately 650,000 deaths from respiratory diseases each year. This year, influenza in the Northern Hemisphere, the season in the Northern Hemisphere, which is still underway, has drawn quite a bit of attention because of the large number of cases in several countries, but also because of the emergence of the so-called Clade K virus. Today, we'll provide you with an overview of the Clade K virus, including its associated risks in the global context and some country experiences in responding to it. We will provide you with information on past Southern Hemisphere seasons and provide an update on current circulating virus strains. We are so deeply appreciated for the surveillance efforts and the work carried out by countries and the timely sharing of data and viruses through the GISRIS network, the Global Influenza Surveillance and Response Network, which includes 165 institutions in 138 countries, areas, and territories. GISRIS is a gem. It's a global good and the foundation of which influenza and other respiratory surveillance, thanks to all of the GISRIS labs, hosting environments, and many supporting partners in this longstanding system. There are so many public health good that come from GISRIS, including the surveillance itself, but the characterization of influenza viruses that are in circulation, seasonal zoonotic influenza viruses as well, the risk assessments that are conducted based on the information that circulates through GISRIS, and many public health products, including an update to vaccine recommendations that happens twice a year in each of the hemispheres. There is another seasonal influenza vaccine composition meeting that's taking place in 3 weeks' time, and this is organized by WHO. WHO continues to emphasize the importance of year-round surveillance for respiratory viruses, including influenza, RSV, SARS-CoV-2, and others, aligned, of course, with national public health priorities. And I would be remiss if I didn't remind all of you that vaccination remains the most effective tool for preventing severe outcomes from influenza. And the ability to update seasonal vaccines for maximum effectiveness depends on the sustained efforts of the countries and the GISRIS network. Countries are encouraged to strengthen their routine surveillance, to maintain virus and data sharing for global monitoring, and to integrate plans to scale up surveillance as part of pandemic preparedness. There are many different preventative measures to reduce the spread of influenza, and of course, there are treatment options as well. But what we worry about is that new next strain. A new Clade X seasonal strain, or even a pandemic strain, can emerge at any time and in any place. And continued vigilance is therefore essential. So have a great webinar, and thanks again for joining. Back to you, Supriya.
Thanks very much, Maria, and thank you for explaining also the key role of GISRIS. It is indeed a gem. Now, we'd like to invite all of you participants to have your say. So as usual, we have our Slido. So the question is, do you consider seasonal influenza a serious problem for you in your life? If you think you've had the flu, do you consider that serious? Um, okay. Yes, no, yes, no. Okay, predominantly yes. We'd like to see some more answers though. There are more than 750 of you online, so let's hear from more of you. Slido.com hashtag 4073432. Please let us know what you think. Do you consider seasonal influenza a serious problem for you? Slido.com hashtag 4073432. It looks like most of you say yes, but 30%, almost 1/3 of you say no. Okay, I will leave the Slido open, so please feel free to share your thoughts throughout the webinar. But I now invite Dr. Wenqing Zhang to moderate the rest of the webinar session. Over to you, Wenqing.
Thank you so much, Supriya. So welcome everybody to this webinar focusing on seasonal influenza. Actually, as we all know that now we are 4 months into the Northern Hemisphere flu season. And then many of you already heard many times terms like predominance of clade K viruses, worst ever season, declaration of seasonal epidemic, and many discussions surrounding vaccines. So today's webinar will provide an overview of Northern Hemisphere influenza season. We will examine circulating viruses and experience from the field. And we'll also highlight some unusual patterns observed in the Southern Hemisphere preceding this Northern Hemisphere season, and very importantly, explain how these complex situations are being monitored and assessed. So let's begin, shall we? Our first speaker is Dr. Aspen Hammond from the Global Influenza Program. She will give an update on the global situation of seasonal influenza. Aspen, you have 15 minutes.
Thank you, Wenqing, and welcome everybody. My name is Aspen Hammond, and I'm working with Wenqing in the WHO Global Influenza Program. It's a great honor to be able to participate here. I'm going to give a pretty high-level global overview and probably go pretty quickly so we can stay on time. But there are links in the presentation for more information, and the presentations will be shared after the webinar. As well, please put any questions in the Q&A so we can address that during the webinar and in the Q&A part. So let me get started. This slide has a lot of information on it, but what I wanted to do is take a step back and illustrate a bit the surveillance of respiratory viruses. Again, coming from the surveillance perspective, surveillance is looking at disease at different levels of severity and different levels of care. So we do surveillance predominantly in primary care and secondary care, and collect epidemiologic information from surveillance done there. But it's also a source of viruses. So patients are sampled and viruses are collected from these samples and can be further characterized and used. And it's this virologic information with the epidemic surveillance data together that is used to inform risk assessment, look at the burden of respiratory disease, do severity assessments, update our vaccine viruses. Sorry, previous slide. Look at our vaccine viruses and other control measures so we can make sure that they remain as effective as possible. GISRs is at the heart of this surveillance. And in the surveillance, our focus is really on quality, not quantity. So really trying to make sure we have systems that are representative, providing timely data, standardized, and have systematic and continuous data collection. Well-established surveillance systems for influenza exist in many countries, as Maria mentioned, and influenza surveillance systems have served as a platform for other respiratory viruses like RSV or SARS-CoV-2 or other respiratory viruses that commonly circulate in the community. And countries might have different systems depending on their national public health priorities. Next slide. So as was mentioned already, I wanted to highlight again GISRS, which is the Global Influenza Surveillance and Response System. This is a long-standing surveillance and response system established in 1952 and coordinating influenza surveillance since 1952. It's a global system fostering confidence and trust through effective collaboration and sharing of viruses and data and benefits, again, based on member states' commitment to a global public health model. The mission of GISRS is to protect people from the threat of influenza by functioning as a global mechanism for surveillance, preparedness, and response, not only for seasonal influenza, but for pandemic and zoonotic influenza. It's a global platform for monitoring influenza epidemiology and disease, and a global alert system for looking for novel viruses, influenza viruses, or other respiratory pathogens, as Maria said. Its core functions are really to support member states in risk assessment, technical support and capacity building, but we also work on updating lab reagents and vaccine reference viruses, doing quality control, as well as making sure that guidance and recommendations and protocols are updated as needed. Next slide. So for people who maybe aren't so familiar with how this surveillance works, I just wanted to look a little bit in detail on how this works, maybe from a patient's perspective. That patients might seek care at a hospital or a clinic where there are sites that are doing surveillance specifically for influenza. There are specific case definitions. If a patient meets a case definition, a sample might be collected, a respiratory swab. And this respiratory swab may be sent to a laboratory, such as a National Influenza Center, where it may be tested for influenza or any other respiratory viruses under surveillance. This information, as well as the epidemiologic information, is shared in countries as well as in global and regional networks, including WHO and databases, specifically databases that collect genetic sequence data. But what GISRS does also is coordinates the sharing of viruses from countries to collaborating centers, as well as essential regulatory labs, so that these viruses can be characterized and vaccine viruses can be developed, as well as informing WHO's recommendations on vaccine composition and use. So vaccine viruses are shared with vaccine manufacturers as well as the recommendations, and this leads to the production of vaccines and ultimately to distribution and getting into the arms of people so we can protect everybody against influenza disease. Next slide. So I wanted to shift now to showing some of the surveillance data that comes through this network. If we take a longer view and we look at surveillance data going back to 2020, this chart shows all these years, and in the colored columns, we can see influenza detections, again, colored by the type and subtype of influenza virus. And we can also see the blue line, which is the percent of samples testing positive for influenza over time. And the red line is the percent of samples testing positive. Sorry, if you just go back to the previous slide, the red line is the percent of samples testing positive for SARS-CoV-2. Just go back one slide. Yeah, perfect. Thank you. Next. Yep. So we can see that during the COVID-19 pandemic, so since in the years of 2020 and most of 2021, influenza activity was very low. You can see the blue line at the zero point there for most of that period, but since then has returned to a more typical pattern of having peaks of influenza, especially around the winter months of the northern temperate countries and also in southern hemisphere temperate countries. Just to note here as well, so we can see that in the most recent season, so influenza activity increased in 2025. We can see the detection starting to go up in around September and increasing through the end of the year, but have come down in January. So looking at the most right part of that graph. Seasonal influenza viruses are predominated by H3N2, as was mentioned, specifically a group of viruses, these subclade K viruses, which have several changes in one of their outer surface proteins compared to their other related H3N2 viruses. And for those who follow this closely, the interesting to note fact is the absence of the B Yamagata detections. So the last one was detected in March of 2020. Next slide. I wanted to talk a bit from the epidemiologic perspective that the exact timing and onset of seasonal epidemics can really vary, as can the duration and the magnitude of each epidemic. These can vary a lot depending on the location and multiple factors, such as which viruses are circulating, relative population immunity, as well as other conditions. As well, the age group that's most affected might vary from season to season. So what I wanted to highlight in these two charts, and this is data that's generated in countries and shared with WHO, really rich data on surveillance. The top one is showing the percent of samples positive for influenza in a country over several years. And the different colored lines show each year. So we can see there's quite some variation. There is an increase each year, but when that increase happens and to the degree at which it peaks can vary by year. And the example in the bottom is showing surveillance data of influenza-like illness cases over several years. But in this case, the different lines for different age groups. So it's difficult to see, but if we look closely, there are differences in between the seasons in which age group is most affected. Next slide. So looking at the most recent situation, so looking to data that covers the week 4 of this year, we are looking at the map on the left, which shows the percent of samples testing positive for influenza by country. So this, again, this is data shared with WHO. We put out a weekly report every week on this. So these are taken from our weekly report. We can see in blue, different shades of blue representing the percent positivity levels. There's quite a lot of blue, especially in the northern temperate areas, but also some in more tropical or southern hemisphere temperate countries. So there is quite some influenza activity still going on at the moment. And looking at the map on the right, which shows changes in this week compared to the previous week, a mixed picture. The pink color highlights countries where there's been an increase in activity, and the blue highlights some countries where there's been a decrease. So some are seeing decreases, some are seeing some slight increases. So a mixed trends there if we look at the global level. But overall, again, most recently, influenza detections have been decreasing at the global level. The other thing we look at, if you move to the next slide, is we have a map looking at the predominant viruses by area. And in most areas, again, it's H3N2 viruses, which are predominant. But just important to say, there does continue to be H1 circulation as well as influenza B virus detection. So H3, while it remains predominant, we do see changes in the proportions over time. So just to highlight some you can see there's a little bit more H1 in Central America and the Caribbean and parts of tropical South America, but also in East Africa, there's a mixture of H1, H3, and B as well. Next slide. And taking another step back, looking back at the epidemiology, I wanted to highlight that we also look at in addition to looking at the trends in illness and viruses, we try to look at how this season compares to past seasons in terms of the severity. That's a question that often comes up. How severe is this season? WHO has issued guidance on doing severity assessments, and this approach allows us to compare current activity compared to what we've seen in the past by setting thresholds. It allows us to be able to try to define the severity of this season compared to previous seasons and looking at different indicators, so transmissibility, but also how severe is the illness caused by influenza. And next slide. So countries that are routinely assessing surveillance, again, using their surveillance data, have also shared this information with WHO, and we also include this in our weekly updates. It's not easy to aggregate everything up to the global level, but if we can generally say, when we look at transmissibility, so what's the degree of the transmission in the community, most of the assessments indicate that it's reached moderate to high in some countries, but especially in children, but not in extraordinary levels compared to what we've seen before. And the severity of the disease in terms of hospitalizations or ICU admissions, generally not unusual compared to previous seasons as well. Next. So the last area I wanted to address is vaccination. As Maria said, vaccination remains our most effective tool towards prevention. WHO has recommendations on influenza vaccination, which groups to prioritize. But from our side, we also look at the effectiveness of vaccines, influenza vaccines each season. This can be done in countries or in regional networks. And vaccine effectiveness, real-world vaccine effectiveness, can vary by season and by product and who is getting the vaccine. So this is something that's really important to look at. And in the next slide, I have quickly summarized some of the preliminary published studies that have come out, especially around, given the emergence of this subclade K drifted virus. Some countries did come out with some preliminary studies indicating, again, that the vaccine effectiveness was quite in line with previous years, reassuring us that this remains an effective tool. These, again, are preliminary estimates, and the end of season estimates may change, but again, give support to the recommendation for seasonal vaccination. Next slide, just to say thank you for your attention. Any further requests for information, our email and our website is listed here. Thanks to all the WHO colleagues and all those in countries and in the GISERS network and our partners for implementing the surveillance and sharing all this information with us. Back to you, Wenqing. Thank you.
Great, thank you, Aspen. So for everybody, the slides will be made available, as there are already quite a lot of questions. If you have questions for discussion, please type on the Q&A, not type in the chat, and they will be picked up. Without further ado, let's move on to the next presentation by Professor Maria Zambon, Director of the National Influenza Center, UKHSA, and she will talk on the Northern Hemisphere situation with a focus on UK.
Thank you, Wenqing. I'm hoping that you can see my slides. Is that okay?
Yes.
Okay, great. Aspen's done a great job of introduction there, so it should be good to actually summarize some of the key points about circulation in the last 6 months. Aspen's clearly indicated that we have seen mostly influenza A, H3N2 in the last 6 months or so. In particular, not every region has been dominated by influenza H3N2. Some regions have seen influenza B, and that was the only point I really wanted to make with this slide, that there are some differences in the different regions, but when you go into the sort of subclades of H3N2, you can very clearly see that the Northern Hemisphere has been predominated by the K variant. There are multiple circulating clades, but predominantly K variant of H3N2. And as mentioned previously, slightly different picture in South America and some parts of Africa. But again, looking at the distribution of the clades over time, you can see very much that the clade K, when it emerged early in the summer, it has grown and dominated, indicating a growth advantage or fitness advantage over other circulating H3N2s. Now, I've put this slide in really to help explain the fact that when you see antigenic variants of, or rather variants of H3N2, you do look at where the mutations are in the hemagglutinin. What we've got shown here is a schematic picture of the hemagglutinin, which includes the antigenic sites as well as the receptor binding sites on the molecule. So those are the key sites where, if we see mutations, we have concerns about whether or not they might be associated with an antigenic variant. And here, mapped on this schematic, is the multiple amino acid changes which are seen in the K variant. And what you can see from looking at this is that these amino acid variants particularly cluster around the receptor binding site at the top of the molecule. And that is an important signal for the fact that we may have an important antigenic variant in circulation. So once you see that type of pattern of mutations, it is a sort of warning signal to take care about the fact that there may be an antigenic variant. And at the vaccine composition meeting in September 2025, human serology studies were undertaken using panels of serum and looking at various different variants that were in circulation. And at that point, it was noted that human sera which had been raised, or people who'd been vaccinated, showed lower reactivities to the recently circulating viruses, and in particular the ferret antisera raised to circulating variants showed significant differences. all of which goes to support an update in the vaccine composition for the next southern hemisphere. And why that's important is that with the recognition of an antigenic variant in circulation and the fact that the northern hemisphere vaccines were not quite a good match or such a good match for the circulating variant, it meant that in September of last year, it was recognized that the northern hemisphere would be going into a season with a vaccine mismatch for H3N2, a situation which doesn't occur all that often, but perhaps will occur once or twice in a 10-year period. But it is certainly a situation which causes some concern from a public health perspective. Here is data from the United Kingdom, where from March through to October, we were monitoring the antigenic properties of circulating viruses. So this is a sort of crude heat map where green equals good and red equals not so good. What you can see in the two columns, which I've highlighted, are the reactivities of antisera raised to either the egg-grown or the cell-grown viruses against circulating strains. And you can see from March to October, we could actually see a gradual trend towards reduced reactivity of antisera to our circulating viruses. So that is, again, an example of concern in relation to antigenicity of circulating flu viruses, because it says that the antisera raised to vaccines may not be optimum and are recognizing a significant antigenic difference. Now, here, what we show is a combination of information, that is the percentage of tests positive for influenza very early on in our winter season. So I've mentioned that the antigenic variation was going on, or the antigenic monitoring was going on in circulating viruses. But in October, we started to see a very early season for us. So that was quite some concern, because you can see with the heavy black line the difference between previous influenza seasons, and indeed in the last 7 or 8 years we really have not seen very significant influenza activity early on. So again, a concern about the fact that we had early influenza activity associated with a known antigenic variation. And for that reason, we undertook a very early interim vaccine effectiveness analysis to try and get a quick read on how much or how well our influenza viruses were being protected against with the current seasonal vaccines. This sort of indicates that majority of the H3N2s that we were seeing were definitely influenza K variant. And so we knew that the indicators we were seeing from our health system were associated with impact due to influenza K variant. Now, as the season's gone on, you can see from the black lines here that we've had what we would call a medium intensity season. It has not reached the level seen in 2022, 23, or indeed pre-pandemic. That's from our primary care indicators. And if we look in our hospitalizations or our intensive care admissions, we've seen exactly the same sort of a picture. A moderate influenza season, which has not been as bad as influenza seasons in recent years. And we also know, as I've said, from the virological data, that whatever we're seeing in our health indicators, this is the impact of the influenza K variant. When we've looked at lab positivity, this is the total sort of testing data from the United Kingdom, we can see that the only age group where we've seen anything even moderately unusual is the 5 to 14 age group, where we've seen somewhat excess detections, and the same sort of picture on the hospitalizations by age group. So the key principle for us has been an early influenza season, but not necessarily a very severe influenza season. Indeed, rather a moderate season on a par with what we might expect normally during the winter season, despite the fact that we are dealing with an unusual or a new antigenic variant of influenza. I now want to say something briefly about our vaccination program. We have a number of different vaccines in use in the United Kingdom. Most of our children under 16 have live attenuated influenza vaccine, an uptake rate there of about 40 to 60%. Our elderly receive enhanced vaccines, and certainly over 65, we have something like 75% uptake of those vaccines, which is shown in this slide. The under 65s at risk is a lower uptake and predominantly trivalent, not enhanced vaccine, a regular egg or recombinant vaccine. Now, when we look at vaccine effectiveness, we use a test negative case control design, which basically we're using the surveillance data and at the same time linking that to information about vaccination, which allows us to make an assessment under the test negative case control design, how effective have our vaccinations been. And here we've looked very early at emergency room attendance and hospital admissions, because for us in our system, that's a good way of evaluating severity. That is, what's taking us, what's causing people to be admitted to hospital or to visit emergency room there. And what you can see from the vaccine effectiveness estimates, we have very good vaccine effectiveness estimates in our childhood age groups, and less good, as we might predict, in the 18 to 64s, on a par with what we might expect seasonally, as indeed the same for the over 65s. So the summary of the early vaccine effectiveness suggests that vaccines were providing, at least in the childhood population, good immunity against the novel variant. And in the older populations, the estimates early were on a par with what we might expect normally for our seasonal vaccine estimates. But also want to draw attention to the fact that when we did the vaccine effectiveness, we did this very early in the season, when you would expect peak post-vaccine immunity responses to be operational. And in order to check that we had not sort of overestimated this, we looked at different intervals post-vaccination. And when you look in the first 7 days post-vaccination, you can see in the results outlined here that there was no effective vaccine immunity. And you can see over time the gradual acquisition of immunity. So one of the comments that came back to us, not surprisingly from this sort of analysis, is the fact that because we'd done this early, was this going to be representative of what we saw across the season? Now, here is an updated interim vaccine effectiveness, which is done in time for the vaccine composition meeting, which is due to be held in a couple of weeks' time. And what you can see beautifully here is the effect of waning of immunity over time. But the key point I wanted to make from this set of data is that the very early estimates that we did in November or rather the more recent estimates that we've undertaken end of January are consistent with the earlier estimates that we did in November and show very clear signs of waning. But the bottom line on all of that is that vaccine is producing good immunity despite the fact that we have had an antigenic drift variant in circulation. So for us, we went into a winter season with widespread anxiety about the H3N2 drift variant. We had a very early season, and we had a lot of commentary in the media and commentary from others who perhaps should not have been commenting quite so much about new superflus, which was somewhat misleading. We did undertake proactive campaigns to encourage vaccination and sort of antiviral prescribing, but overall we've had a moderate winter season. It is true to say that health service pressures continue to be experienced, but those were not kind of overwhelmed by influenza. The vaccine performance gave us reasonable point estimates for the children's vaccines. In the adults, moderate vaccine effectiveness estimates, and we have similar data from the other countries of the United Kingdom. There is greater uncertainty overall about the H3N2 subtype specific estimates, but we should be able to refine those in our final estimates. And I think those would be the key points for me in order to try and wrap up and keep to time. I hope that sort of makes it reasonably clear what has gone on in the United Kingdom this winter, and I'll stop there.
Thank you very much, Maria, for this very informative presentation. I understood actually you would have to leave in about 5 minutes time. So let's have a Q&A session now before actually we move to Professor Ian Barr's presentation on Southern Hemisphere. And we've already had quite a many questions already. Maria, maybe you can cover a couple questions, and I will also ask Aspen and Ian also. The first is the field management, like the clinical management in UK, vaccine response, and also a question about why specific age groups like the 5 to 14-year age groups are most affected so far. Please provide some of your views. Would you also please also comment about the severity? And you said it's moderate in UK so far, but maybe from virology perspective also to look into those. And on the severity, if you have any other points also to add about severity, how they are measured. The same question, I will also go to Aspen and Ian. Maria.
Okay, thank you very much. I'm not sure yet what to make of the 5 to 14, the signal seen in the 5 to 14, because I think in order to properly interpret that, we will end up needing to look into a deeper dive about the vaccine uptake in that particular age group. It may not be a particularly useful signal to focus on. The only reason I picked it out was because it's the only one which shows any difference to anything else we might have expected, showing perhaps slight excess in that age group. So there are things that affect that, including testing policies. I don't think we can sort of firmly conclude what that signal means just yet. And probably we'll have a better answer for you when we have our final vaccine effectiveness estimates right at the end of the season, which will be March, April time. In terms of severity, we would not, I think, call this a particularly severe season. The indicator which was important for us was an early influenza season. So there you see the impact of influenza much more clearly. But when we look at the overall impact in the health in the health system, looking across a number of different indicators. So that is consultations in primary care, emergency admissions, which could be an indicator of hospitalizations, ICU admissions, and emergency room attendances. We have a good idea of how to calibrate that against previous seasons. And at the present time, it looks like a moderate influenza season. I haven't yet seen our mortality estimates, but what I do know is that we have not seen any excess in pediatric deaths, which we would normally expect to see when we have a serious drift variant. So those are the points from me about severity on this point.
Maria, as you need to leave, I think people are typing in more and more questions specifically for you. So maybe let's go to a little bit further about specific for UK, like what type of vaccines are being used, whether you've seen differences in the VE so far between live attenuated and inactivated vaccines, etc. I wondered whether you have such information already.
Yes, so in fact, both of the slides, I've showed at least 2 slides which do indicate the differences in vaccine effectiveness against the different types of vaccines. Now, we do normally try and do some kind of an estimate on vaccine types at the end of the season. What we're able to do at this point is to look at vaccine effectiveness in age groups and take that as a proxy for the type of vaccines, because in the 0 to 16-year-olds, the predominant vaccine which is used is the live attenuated vaccine, but there is some use of inactivated vaccines. So the vaccine effectiveness, when we do it by age, if we see, as we have done, good vaccine effectiveness there of around about 70%, we take that as a proxy for our live attenuated vaccines. In the elderly, we're looking for enhanced vaccines. So we do it by age, but we know that there is stratification of use of vaccines. Afraid I'm going to have to go, Wenjing, but if I will look at the questions and try and theme them afterwards to provide some answers for folks on some of the detailed questions.
Sure. Thank you so much, Maria. And the questions will be summarized and provided to you. Safe travels to you. So let's move to Aspen and to Ian. Maybe you can also comment on the questions about severity, as well as the clinical management and the vaccines, etc. Who want to start? Yeah,
maybe I can start quickly. I can address the methods for assessing severity. That's probably where I'm best placed. I think Ian will probably can better describe the situation as in his presentation. But in terms of methods for severity assessment, what the WHO guidance goes into detail on is using historical surveillance data to estimate thresholds of activity. And then using these thresholds, then we can look at our current data and in the context of these thresholds and say whether, compared to what we've seen previously, current activity is in the low area or in moderate or high or extraordinary. So extraordinary would be something that we really rarely ever see. And so that's the basic concepts behind it. Because influenza disease is quite complex, the severity assessment methods are looking at different indicators. So one we look at is transmissibility. So how quickly and how much is the virus spreading in communities? So how much illness is it causing, especially in terms of outpatient illness? But another indicator is to look at the severity of the disease. So of cases that are hospitalized with respiratory disease, how many of those end up in ICU or how many are fatal cases? So this can give us an indication on the actual severity in terms of the clinical severity. Another indicator that we look at is the impact. What's the impact on the healthcare system? So how are the hospitals coping with the influx of patients? So we look at severity in terms of these different indicators because the season severity can differ from one to the other. I think, as the early indication we're getting is that transmissibility was quite high, and it spread quite quickly in many countries. But overall, in terms of the seriousness of the disease, it wasn't that unusual compared to what we've seen previously. So it's important to look at these factors individually. Thanks.
Thank you, Aspen. Ian?
Yeah, I'll show you a little bit of data on hospitalizations, ICU, and mortality. They're the classic measures. The other ones which you can use are length of stay and medically attended influenza. So they're all the classic ones, and they're the easiest ones for us to measure in terms of severity.
I think it's the right time. Let's move to Ian, your presentation. It will be very interesting to look at the Southern Hemisphere season preceding the Northern Hemisphere season. Ian.
Okay, thank you. And Ching, can you see my screen?
Yes.
Okay, great. So I've been asked to give a little bit of an update on the Southern Hemisphere, and of course I'm going to focus a lot on Australia's situation because that's where we're based, in Melbourne, Australia. So you might be wondering why on earth Southern Hemisphere is even getting a Guernsey at this talk fest. It's summer down here, so we shouldn't be seeing any influenza. We should be enjoying an influenza-like illness or influenza-free season. But we haven't been, and I'll show you some of that data, at least in Australia. And, sometimes we can learn lessons from what's happened in the Southern Hemisphere. Some of those things translate to the Northern Hemisphere in the following season. And sometimes it's the other way around. Sometimes we get the worst end of the stick from the Northern Hemisphere with the viruses traveling down to the Southern Hemisphere. But this time around, I think it's pretty evident that a lot of the virus pool came from the Southern Hemisphere, and especially from Australia and our region. So this is just showing you one of those typical flu net plots with the classic influenza Bs in orange and the influenza As in that bluey, greeny color. And I've just shown here 2 years. So 2024 on the left-hand side and 2025 on the right-hand side. So this is the 2024 is a relatively typical season where we have a main peak and then we have a trailing off of seasonality. And often that's associated with influenza B viruses. On the right-hand side, you can see in 2025, it was quite different. So we've seen in that period, in that trailing period, very little influenza B, or much less influenza B than the previous year, but a rise and an actual peak rather than a trailing of the influenza cases reported through the FluNet system. And if you look closely there, it's always a bit hard to tell the influenza H3 and the H1. The H1's the lighter blue and the darker greeny blue is H3s. And you can see that a lot of that contribution from that second peak in 2025 was due to influenza H3. And yes, you've already guessed it, a lot of that is the K subclade. So when you look around in Australia's cases here in WHO speak, we have 3 NICs, so there's 3 different sites that collect data, and that shows a similar sort of trend where we had quite a prolonged season in Australia and then a tail at the end. However, there is better data available when we look at the total picture of Australia. So this is a system called the NND, or that's the last few months there from October onwards. But we have better data from a system called the NNDSS. So this is a system which reports into the whole of country cases of influenza which have been lab confirmed. So all the labs automatically upload their data. So you can see in that left-hand bottom graph there that in 2025 we had quite an extended season, and the area under the curve shows that it was a big season. In fact, it's the biggest season we've seen in the last 20 years. And that right-hand graph, I apologize, the colors are a little bit light, but you can see in that light gray is influenza A unsubtyped, and then the yellowy color is influenza B. So you can see the first part of the season there was influenza A unsubtyped, and then influenza B and then a second peak there, which was mainly influenza A unsubtyped. What you can, if you've got very good sight, you can see the subtyping data on the bottom there in green for the H1 and in red for the H3. So the majority of the season was H1 until the end of the season there, and you can see that sharp rise and that inset there with the H3 cases. And this persisted right through until December. So you can see there the last 3 months of the year in 2025. In Australia, we had 109,000 influenza cases and much more than 2024, 5 times as many, more than double in 2023 and more than 10 times 2022. So this is an unusual event to see this level of activity late in the season in Australia. And it wasn't just Australia in the Southern Hemisphere that had this late breaking outbreaks of influenza, and it was mainly H3. So you can see in New Zealand, it was a similar case there. So the viruses which were subtyped were mainly H3 viruses towards the end of the season, which was different from early in the season where it was influenza B and H1. New Caledonia, a nice place to visit for Australians and New Zealanders. We managed to get the viruses in there as well. And Fiji, another holiday spot not too far from Australia. They had an outbreak of H3 again out of season for them. So the viruses spread quite quickly from Australia to Pacific countries. And not only Pacific countries, then there's also other regional countries that have a lot of travel from Australia. So Singapore, the Philippines, and Thailand all showed this late breaking H3 outbreaks from September, October onwards. Singapore a little bit earlier. In South America, the situation was a little bit different. You can see there is some H3 activity, but if you look at that last period again, there's quite a bit of a rise there in Chile, not much in Brazil, and not much in Peru. When you look at what the subclades were, there were some K viruses in Brazil, but very little in Chile. And these were other H3 viruses from the earlier J2 clades. So quite a different picture in South America, as Maria's already mentioned. And this is the situation. This is just a slightly different take on things with different color schemes than what Maria showed. And the orange is the K viruses, and you can see there the predominance of those K viruses in the Southern Hemisphere, in South Africa, Australia, and Southeast Asia, and also now in the Northern Hemisphere. So this is in the last 6 months of the data which has been entered into NextStrain. And you can see similar effects in the US, and what I mentioned there with South America only showing a small number of those K viruses in Brazil and very little else happening in Chile, and unfortunately no data from Argentina. So this just shows you the global growth in those H3 K clades. Australia, you can see they started quite early. So did the US, and then global picked up very quickly thereafter. K is shown in the orange color there. And one thing we did when we were looking at analyzing our viruses last year was to try and map out where these viruses might have originated. So you can do the simple thing and you can do date matching, but this is a more sophisticated Bayesian technique which looks at the phylogeny of the viruses and where they've come from. So if you just look at the dates, the earliest dates which we could find K-clade viruses were from the United States in New York, to be exact, in June in 2025. And then July, a couple of other states in the US had reported cases or detected cases. And then we saw very soon after in July cases in Australia. So these lines here connect up the places where we can confidently say that the viruses have gone from one place to another. And the thicker the line, the more confidence we have in those viruses coming from that place. So, for example, there's a very strong connection with viruses being transmitted from Australia to New Zealand in the bottom right-hand corner. And some of the other lines are not quite as confident, but United States has obviously been a source of viruses into Europe and to parts of Southeast Asia. So this is an interesting way to look at origins and the way that viruses travel around the world and how quickly they can go. So we mentioned there about severity, and here's some data from Australia showing the different age groups and showing the severity of influenza as measured by attendance in hospitals. And this is done by different age groups. And I've just highlighted the last 3 months, October through to December here. And you can see there that while we had a reasonable number of cases, the number of hospitalizations was relatively minor. It was in those age groups, those 4 to 15-year age group had the predominance of those admissions. But that's not unusual. It's usually either very young or in these age groups, which are overrepresented in hospitalizations usually. But you can see there were hospitalizations here, even in the over 65, but nothing too dramatic and nothing unusual, apart from the time of the year when these cases were detected and the cases were admitted to hospital. And you can see here, if you've got very good eyesight, that the majority of those which were subtyped were H3s in this period, which is not surprising because that was by far the majority of viruses which were circulating. So we also looked at pediatric admissions into one of the hospitals. This is some of the early data here. And what we did is we looked at the K viruses and we compared those to the non-K viruses. So earlier in the year, we had these J2 viruses predominating in Australia. Then we had a quiet period, and then August, September, October, we started to see these K viruses appear. So you can see here that in this early study here, we had 39 viruses, which were the K viruses, and 30 which were the non-K virus. So really not much difference in terms of a predominance of cases hospitalized, and there was no difference in ICU. In fact, there was only one ICU admission out of those 71 cases of influenza H3 admitted to this pediatric hospital in Sydney. So no strong signal there that there's any difference or more severe with the K viruses compared to previous circulating clades. We can also look at mortality, and this is some mortality data taken from the Australian Respiratory Surveillance Report. And again, if we're looking at this period, we've also got deaths due to COVID and deaths due to RSV on this graph, but let's just focus on influenza. And there's 3 years on here, 2023, 2024, and 2025 shown in the dark blue. And you can see there may have been a slight increase in 2025 in October, but November didn't really show much increase there. So no clear signal on mortality either increasing with the H3. And you can see in earlier parts of the year when H1 was predominating, there was a lot more deaths. Again, there was a lot more virus in circulation than towards the end of the year. So if you want to read about some of our early observations, this was a paper published in mid-December in Eurosurveillance, so you can go and look at that. There's quite a number of figures and data in that if you're interested. So what about H1 pandemic viruses? Well, I've just taken a snapshot from NextStrain because that's the easy way to work out what's going on around the globe. In the Southern Hemisphere, we're seeing mainly D3.1, so this is another subclade designation here. This was what the vaccine will be in the Southern Hemisphere in 2026, so hopefully that will be a pretty good match. And the other one, which is a slight variant with a few changes compared to the D3.1, is its sister clade, if you like, D3.1.1, and that's shown in that orangey color rather than the yellow color. You can see in Australia we haven't seen too much of that. Southeast Asia hasn't seen too much of that, but North America has quite a chunk of those viruses, maybe a bit more than a bit less than half of their viruses are that D311. So interesting to look at. I think there's not as much diversity with H1s as there is with the H3s over this period. What about bees, BVICs? Again, it's a pretty simple story across the world. Of course, there's always one exception, and this exception is the United States. So the United States is seeing quite a different picture from what we've seen in the rest of the world. And again, this clade designation of C3.1. So these are quite different in terms of their antigenic characteristics when we test them using ferret antiserum. and against human serum pools or human serum panels against previous B vaccine candidates. The rest of the world is seeing mainly of these very closely related C5.6 and C5.7 shown in the orange and the red colors here. So I think it will be very interesting to see whether this C3.1 virus gets out of the United States and has a bit of a run around. You can see there are a number of those C3.1s detected in Australia and in Japan, but they are the minority of those viruses. So in some countries, they have definitely not won the race, and others, like the United States, they seem to be, for some reason, doing very well. So in summary, Australia, New Zealand, and many Southern Hemisphere countries, influenza H1 was a predominant virus in 2025 winter. However, from August, September 2025, H3 viruses increased in many of those countries, and the subclade H3s, as we now term it as the K subclade, was responsible for most of this increase, except in South America. I think K viruses have been responsible for the very extended season in Australia and New Zealand. Fortunately, that's now tapered off in January, so hopefully we'll get some relief going forward. And Australia appears to have a pretty big role in amplifying these viruses and clearly have exported them to various countries such as New Zealand, Singapore, and other Southeast Asian countries. As you've heard earlier, the K viruses appear very fit. They're highly transmissible, but don't have increased severity versus other previous circulating H3 subclades. All age groups are susceptible to the K viruses, but the tendency is to affect children more. This may have a bit of a bias in testing, but similar to what Maria Zambon mentioned, our greatest numbers have been seen in the 5 to 14-year-olds. So there's just a little bit of talk here about subclades, and the K came from a previous similar virus called the J2.4, and that was originally called J2.4.1. Why do I tell you this? Well, the Southern Hemisphere vaccine, as already mentioned, is a J2.4 virus, which is reasonably closely related to the K. So we're hoping that will be a good match for the Southern Hemisphere in 2026, or if the Northern Hemisphere use that vaccine. But more likely, there'll be an update to the K virus, or if anything else breaks, that virus moving forward into the Northern Hemisphere 2026-2027 vaccine. So as Maria has shown you, the 2025 Southern Hemisphere and the 2025-26 Northern Hemisphere vaccine appear to offer good protection against the K viruses. Our data does not look quite as good as Maria's on our vaccine effectiveness. However, we don't have the LAIV, the live attenuated vaccine for children. That's coming later this year, but was not available in 2025. So that might explain some of the differences in vaccine effectiveness. So importantly, and I don't think this has been mentioned, the K virus is susceptible to all the neuraminidase inhibitors. So zanamivir, lenacapavir, peramivir, and more importantly, oseltamivir, and also the PA inhibitor baloxavir marboxil. We haven't seen any resistance whatsoever to date. So as already mentioned, the BVIC viruses continue to circulate, and there's some heterogeneity there with the C3.1 subclade predominating. No BEM viruses detected, as Aspen has mentioned, and the BEM has been removed from, I think, all vaccines globally. So that's one less problem to worry about. So just acknowledgements of the data sources and the people who've done that, and thanks to everybody that's contributed viruses to our centre. That's been a fantastic collaboration over many, many years. Thank you, Wenqing.
Thank you so much, Ian. So we still have some minutes, and we can have actually quite interesting Q&A indeed. So Aspen, Ian, and me, we three, let's have some good time. Let's go to the first question for Aspen about seasonality. And obviously, this Northern Hemisphere in many countries, it shows earlier season. Maybe you can comment on the seasonality, earlier season, whether there will be multiple peaks and what is the historical phenomenon, etc. Aspen.
Yeah. I think it's risky to make any predictions. Things are notoriously unpredictable here, but I think some of the questions on the timing, some of the things that I find interesting is that the increase and the peak seem to have happened just at the end of the year, and it's a difficult time because we know that there are a lot of changes in healthcare seeking behavior as well as surveillance practices. So these can cause some artifacts in surveillance data. So it's typical to see at the end of the year a decrease in activity, which is, again, usually an artifact due to surveillance. But now that we're a few weeks out of the beginning of the year, we are continuing to see a decrease in influenza activity, which is reassuring. But we know that seasons can be longer than usual. Sometimes there is a peak of influenza B activity following a peak of influenza A. So I think it's difficult to say right now what will happen. But again, for the past few weeks, we've been on a decreasing trend and hope that it continues that way. But the timing, the predominant virus, a lot of these vary from year to year, so it's quite difficult to predict which virus will be predominant in the next season, and what the timing and severity will be in coming seasons. Over.
Indeed, as we've seen from the slides of Maria and Ian, that the curve of this season may start earlier. So maybe at a certain time point, oh, the season is worst ever than ever. But if we look at the whole season, it may not be the case. So we do need to look at, as a whole instead, and there's a complexity there. Let's move to the second question to Ian about the vaccine composition. So this Northern Hemisphere season, the vaccine composition, it didn't include this clade K component, but we actually showed the results quite promising. Just to share some of your insight on why.
Yeah, well, the K viruses didn't exist when we made the decision for the Northern Hemisphere, which is made in February in 2025. So then the vaccines are made for the season, and usually vaccinations occur in August, September, and October in the Northern Hemisphere. So we do our best to try and forecast what might happen, but if we haven't even seen the viruses, then I think it's extremely difficult, i.e. impossible, for us to look that far forward. What we have seen, though, I think, which is very reassuring, is that even though we don't have a perfect match, that the vaccine, which was produced and used in the 2025-2026 Northern Hemisphere, has been highly effective, at least in the younger populations, and probably typically protective, typical sort of numbers for adults and elderly that we normally see with H3s, which are very hard to protect fully against. But I think, in terms of hospitalization, we've got early data on vaccine effectiveness in Australia, and it looks typically reasonable, if you like, not what we might have been expecting.
Thank you very much, Ian. So as Ian explained, that although you may hear from the media it's mismatch, etc., it sounds shocking. But actually, after using the vaccine, it can protect people, from, at a certain percentage, quite promising, from attending hospitals or being hospitalized. Let's have the last question before I hand over about surveillance, because there are quite a lot of surveillance about how actually we strengthen surveillance in low middle income countries, why there are so many A virus, not subtyped, and whether there will be prolonged Northern Hemisphere season. Prediction again. Ian, would you want to start and then come to Aston?
Yeah, look, I think that's an interesting question about whether or not you'll have a prolonged season. I think that will depend a little bit on, how quickly it spreads around in the Northern Hemisphere. I think what we saw in the UK was a very explosive start to the season and then a rapid decline. So it obviously ran through the country very quickly. So that may not be the case for other countries which are larger or not as well connected as the UK. So, I think it will vary from country to country. What was the other part of the question, Wenqing?
Strengthen capacity in low-middle-income countries, a virus not subtyped.
Yeah, so that's not just a product of developing countries; it's a problem for developed countries. So in Australia, only about 2 to 3% of viruses are now being subtyped. A lot of that is to do with the use of multiplex. The multiplex platforms rarely subtype. Most of them just do influenza A or influenza B. So it's very unfortunate. But for the lab people online, the more subtyping you can do, the better. And I would encourage you to use multiplexes where possible that have the influenza subtyping capacity.
Thank you, Ian. Aspen?
Yeah, maybe I just comment on the last question about the longer season in the Northern Hemisphere. A little bit to what I said already, but also to say, I think if we can advocate also for continued quality surveillance to really help us understand, what the seasons are like in terms of severity and how long. So we advocate for year-round continuous surveillance to try to understand the timing of these seasonal epidemics as well. Thanks.
Okay, so let me also comment about surveillance, as there are also a couple of questions about data, whether WHO will be able to have the data from US, etc. So just for everybody to know, this week we have WHO is having the executive board meeting this week. So those issues are being discussed. But from influenza perspective, everybody in the world, including people from US or elsewhere in the world, all believe for doing influenza, they would need a globally coordinated efforts. As we all know, the next strain, clade K or clade X next time, or even a pandemic strain could emerge anywhere in the world. And GISRS, this global surveillance system, has already been set up and functioning for almost 75 years. So it's a demonstrated model and working year-round of those. So this is a comment I would like to provide. Thanks everybody for joining this webinar, and thanks to our members in the global system, the hosting countries, our partners, including also private sectors, manufacturers, but also like GISED as well. Everybody supporting these great efforts. Thank you very much. So with this, I hand back to Supriya.
Thank you very much. At EPI-WIN, we always have a range of fascinating webinars, but I think today was even more fascinating than most. So thank you, huge thank you to all the speakers. It was just amazing. And you can see from the emojis that are flying up that most participants also agree. And we continue, we had right now, we still have more than 700 people, 750 people, which goes to show how much people appreciated this. I would like to now, before I say thank you to everybody, very quickly ask our participants, what is the most important thing they learned today? A huge range of topics were covered, of course, subclade K, but also the impact on the role of GISRIS, a little bit of a peek into the future as well from Ian, and many other important issues. But what is the most important thing that you have learned today that you will use? I'd like to ask our audience very quickly before we leave, slido.com, hashtag 4073432. So we're getting importance of surveillance. Well, just knowing is what they find most important, I think. New strains, vaccination, new strains, vaccine efficiency, vaccination of children. Well, that's great. The takeaways is just knowing about these helps people. severity of K clade. Right. Okay, I will stop sharing. This is just, but continue to put your inputs in. I just wanted to get a sense of how people felt about what they learned today. I'd like to thank all the participants, first of all, for being here in large numbers, for asking interesting questions. I'd of course like to thank each and every one of the speakers, Wenching and Aspen, for organizing this whole webinar. They worked very hard on it. Professor Maria Zambon and Professor Ian Barr, for making the time to attend in spite of their very busy schedules. So really appreciate that. Thanks to Maria Van Kerkhoff for being present to speak to you in spite of being busy with the executive board meetings here. But I'd also like to thank everyone who's worked in the background, Michael Tabizescu and Armoral Duncan, who's been doing all the background work. So this and our partner, Project Echo, particularly Kanika Sachdev, who's been helping us throughout the webinar. So it's been a team effort. Thank you very much. It's always a pleasure. And next week, we have something a bit unusual for EPI-WIN. We have a very focused webinar series on 2 days, which is ship inspection and issuance of ship sanitation certificates. It's after the updated IHR. Our border health team is holding this EPI-WIN webinar primarily for port health officers and public health inspectors. However, if you are interested, you're welcome to join. It is open for everyone, but it is, of course, very specific and aimed for port health officers and public health officers. And we have more exciting webinars coming up towards the later part of the month and in March. So watch this space and hope to see you soon. Once again, huge thank you, Wenching, Aspen, Ian, and Maria. Thank you very much and have a wonderful day.
Thank you. Bye-bye.